Hello, welcome to this special webinar for the HSJ Patient Safety Congress in partnership with the International Society for Rapid Response Systems. Today we're going to be discussing the issue of deteriorating patients and also the development of the new NEWS2 system to help identify patients and save lives, hopefully. We've got some excellent guests with us today who are going to explore this topic and talk to us about the development of NEWS2 and how it's going to be rolled out across the NHS. To my left, we've got Dr. Matt Inada-Kim, who's a consultant at Hampshire Hospitals and also a clinical advisor for sepsis and deterioration, and also lead for Wessex Sepsis and Deterioration as well. To his left is nurse consultant for critical care and critical care outreach, John Welch from the University College Hospitals London, and who's also the president of the International Society for Rapid Response Systems. So gents, thanks for joining us today and talking about this really important issue. We've got some questions that have come in from the people who have signed up on the webinar, but I wanted to kick off first of all just to set the groundwork for our discussion today and to talk about and to ask each of you from your different perspectives the problem of the deteriorating patient. How significant is that for the NHS, for the system as a whole? So Matt, I don't know if I can pick on you first, if you could.
So out of all the challenges we face in healthcare, I think deterioration, and particularly the communication with deterioration, is probably the most amenable and potentially reversible. It's the low-hanging fruit, and it's something we've always put in the two difficult baskets up until now because of our non-standardized language of deterioration. And that therein lies the issue. If you don't standardise the language, it becomes very difficult to measure processes, outcomes, and essentially improve the effectiveness of the whole care pathway from home all the way to hospital and back again.
But you say low-hanging fruit, but I mean this has been a multi-year journey to get to this point, hasn't it? Are you in some ways a little disappointed that we're still?
No, because I think however we addressed it, it was always going to take a lot of worthy attempts to get to a point where there was enough will to do something slightly more radical. And I think one of the most radical things that we can effectively do is essentially issue an effective mandate to ensure that everyone is speaking the same language. So it's a massive thing that has really not happened anywhere else around the world, and represents a really exciting example of what can be done when there's enough will.
Yeah. John, give us your perspective on the problem that this is all attempting to solve, because in your work day to day you must see this on all the wards everywhere. It's part of your day-to-day job, isn't it?
Yeah, so I've been in this field for 20 or 25 years now, and from a background in critical care, intensive care. So we first noticed around 20 years ago that the sickest patients coming into us in the ICU were not from the emergency department or the operating theatre. They were from within our own hospital. They were patients on wards who'd often been on the ward for maybe quite some days or even weeks, and had generally suffered a slow deterioration that had not been picked up in time, had not been treated in a useful way, and then the patients collapsed and ended up in ICU. So I was part of the first group of people that started to think about that, and really to take the sort of thinking that we use in ICU, which is largely about monitoring physiology, monitoring vital signs, and employing those systems out there on the wards. And there's no doubt, as Matt said, the number one cause of avoidable death in the hospital is unrecognised or undertreated deterioration. And we know that, and it's consistent across this country and indeed across the world. This is not just a British problem, and collectively across the world we're learning how to deal with it better. But Britain, as far as I'm aware, is the first country to pull it all together and develop a standardised system that we can use in the hospital and beyond. That's the key thing, and beyond, to make sure that we're all speaking the same language.
So obviously that we've set the problem and we've got the development of NEWS1, if you like. But before that, pre-NEWS, what was was this just ignored, or was this not tackled in any way, or how did we identify the sickest patients?
So, I mean, really, the first understanding of the issues did sort of arise in the 1990s. There were a couple of important reports that were published in the mid to late 90s that showed patients coming to ICU, one, not recognised, two, not treated, and three, did badly as a result of those things. And I guess it's fair to say that those were not popular publications at the time. A stone was lifted on British healthcare at that time, and to start with, people said, well, that doesn't happen in our hospital, it must be confined to one or two small hospitals. But when we looked at it across the board, when we looked at it in each and every hospital, we realised that more or less the same issues were occurring everywhere. So lots of efforts were made to start to develop early warning systems, and there was a multitude out there, and that was a thing. Probably 100 or maybe more than that were developed locally, all generally based on saying, well, a high respiratory rate or a low blood pressure, that kind of thing probably means something important, but with very little real data to say what were the right levels and which were the levels at which they should be escalated for help. And the great thing we were able to do in the last 10 years is, because some of the wards in some hospitals started to record their observations electronically, is to get a database together of signs and to follow patients through so that we knew which were the right parameters to measure and which seemed to be the critical points at which intervention should occur. And a lot of credit should go to Gary Smith's group in Portsmouth hospitals and related hospitals in developing that database and that thinking. And they developed the work that eventually became the National Early Warning School.
And Matt, John made a comment there that I wanted to pick up with you. He talked about people saying, well, this doesn't happen in my hospital. And what we're talking about here has been a little bit of a cultural revolution, hasn't it, to get people to accept that this is an issue. Is that something that you've come across, and how important is it that we face up to that?
Well, firstly, if you look at leadership in hospitals, it's not because they don't want to accept it happens there. It's because sometimes they're just not aware. And sometimes it takes a critical incident or a series of cases that go to coroner, that go to the SIRG group or the Serious Incident Review group, that builds up a momentum and a memory that something here is amiss. And it's not just those events alone that lead to a cultural change and lead to leadership taking it on. It's advice and directives from national arm's length bodies. It's the voice from the clinical floor, which keeps going and saying, we have an issue here, this happens. And I think you touched on an important point in the sense of, this is an issue which happens everywhere, in every organisation, be it in the community, be it in transportation, and be it in an acute hospital setting, and every single department. And anyone who thinks it doesn't is kidding themselves.
Can I interrupt there?
Yeah, of course.
I think it's also important to say, though, that over the years, certainly in some locations, maybe in many, there has sometimes been a bit of a tendency to ignore some of the data that's emerging. And maybe one of the important things is that there's been a little bit of a shift to be more open and honest about these issues. And I'm not sure that's always been the case. And it's incredibly important to emphasise that we need to talk about these issues.
And obviously with the development of NEWS and NEWS2, we're now having a sort of a systemic industrialised debate, aren't we, about these issues? And let's touch on NEWS2 now. I mean, if I can ask each of you your thoughts on the new NEWS2 and how that differs from its first iterations and what some of the key elements of it are. And Matt, if I can, because sepsis obviously is something close to your heart, and here NEWS2 can be really helpful, can't it?
Yeah, I mean, the dedicated chapter on sepsis within NEWS2 has been incredibly useful, very well penned section of the news, and it essentially puts right in front and centre the fact that sepsis and an infection with badness is not a separate condition from all-cause deterioration. They are married and joined at the hip, and you separate them down an individualist pathway at your peril. Because when someone goes sick or comes in sick, you just can't tell what's wrong with them. You have to have a catch-all system that picks up someone at risk of dying. And that's what the design of NEWS has been around. In terms of the changes, there's been, apart from the chapter on sepsis, there have been three main areas. One is the addition of 2 oxygen saturation charts. So instead of having a bog standard oxygen chart that copes with all comers, there is a standard one for those with normal lungs and normal oxygen levels and normal carbon dioxide levels, and a second chart that focuses on those at risk of hypercapnia, so carbon dioxide elevations due to oxygen poisoning, so which is a common sense move, and one that clinicians have embraced really. And the second one is the addition of new confusion to the level of consciousness section. So instead of a pre-existing scoring scale of 0 if you were alert, and a score of 3 if you had any detraction in response to voice, pain and being unresponsive, you now have the addition of new confusion. So it's become akavupu, that essentially enables you to pick up delirium. Again, a great hallmark that someone is becoming particularly unwell. And then finally, the third aspect was the prioritization, quite rightly, that it's your aggregate score of a NEWS that is so important, not a single red parameter. Because we know from evidence that small deflections across a whole series of observations, be it respiratory rate, blood pressure, oxygen saturations, heart rate, predicts who's going to do badly. It's not an extreme observation, a single extreme observation that does that.
And John, your thoughts on the new NEWS2? Presumably you welcome all of those additions. From a nurse's perspective, the nurses are filling these things in every single day. Do you think they will welcome these additions? They'll see the value of those?
Well, just to start with, what I think is, in some ways, the biggest change is the introduction of new confusion, because the second respiratory scale will only apply to a relatively small number of patients, but new confusion will probably be found much more widely. And I think it's worth pointing out that the people that have put together the original database that fed into NEWS, the Gary Smith's group, their intention was that anything less than full consciousness would come up as VP or U on the AVPU scale. But it sort of turned out that in real life, people have been recording people with somewhat some confusion as being A. That's generally what's happened, and people's consciousness has to be quite depressed before they're recording VP or U. So we've sort of missed a trick on that. And in some ways, I think the introduction of new confusion is really a correction of maybe what we ought to have done in the first version of NEWS. And it also highlights the increasing interest and the increasing understanding that slightly impaired consciousness is a really important signal, and delirium is a really important signal. So I think we welcome it, but we also understand that there's work to be done across the board, really, for people to assess more effectively this phenomenon of new confusion, because perhaps we haven't done enough work at scale to really get that in place. And I suspect that might be the biggest challenge with the new NEWS.
You're nodding your head there.
Yeah, I agree. I think John's right. And so much of this is down to how this is operationalised in local environments, how well this is taught, how the wording is so important in these things. So there's absolute clarity that the right processes are undergone to actually understand whether this is new and different for the patient. And as much effort is put into actually ascertaining baseline in terms of that cognitive function and usual behaviours. But it forces everyone to really think about patients and the way they behave, which it goes deeper than just a warning score made up of physiology. It goes to the heart of what probably deterioration represents.
And I'm presuming as well that listening to patients' relatives and hearing what they say about what is normal for their relative versus what's abnormal, I mean, that's a crucial problem that you see sometimes in stories where things have gone wrong. It's the families complain, we weren't listened to, we tried to tell them, etc. So do you think NEWS2 can actually help drive people towards that?
I mean, a key part of the cornerstone of good medical or nursing care is that relationship with families. And if you don't start from that baseline of what someone is like, a patient is like normally, what their level of functioning is normally, what their cognitive function is like, and carers, relatives haven't expressed that to to a healthcare professional. I think it would certainly, if I was the carer or family member involved, I'd think I wasn't listened to because they didn't even ask what you know my father is normally like. So I think it all helps that conversation. It improves the communication and the sense that there's the bond of trust and the desire to really get to the root of the problem, and the root of deterioration is being listened to, instead of cold hard going in for the medical and nursing symptoms rather than the holistic view.
And John, sticking with this issue of confusion and highlighting delirium, those kinds of issues, we know as the population gets older, more long-term conditions, like so almost a third to maybe 2/5 of wards are full of people with those kinds of comorbidities and conditions. Have we been missing those patients before this was included in news? Is there a risk of that, and will this prevent that, do you think?
So, well, I think the first thing just to be clear about is we do need to understand more about chronic confusion and dementia, and obviously that's a huge and expanding area, a problem area in all kinds of ways. But what we're talking about in this context is, as Matt says, a change from the baseline. So it's new confusion that didn't exist last week or last month, and being clear about what the patient's baseline is and what's happened in the last week or the last month that might have changed that.
And those patients are more susceptible, though, aren't they? There's those elderly patients coming into hospital a few days in, they can deteriorate in that way, can't they, and develop new confusion?
Absolutely, yeah. So there are all kinds of aspects of physical illness and the change of environment and the medications that they might be placed on that probably makes them a little more likely to develop new confusion. So one of the risk factors is just being over 65 or being old. I'm getting there myself.
Yeah. And I think it's worth pointing out that sometimes a change in that cognition, behaviour, and perhaps an increase in confusion can be the only sign something's going on. Think about all the patients that don't really have a voice, those with learning difficulties, mental health, advanced dementia. You know, that can be the only signal. And I wouldn't say we've ignored it up to this point, but it certainly hasn't been a part of the scoring system up to this point. So I'm really excited to see it in.
So having that in the toolkit is a real.
It forces us all to think about, you know, whether a patient is more confused or not, and you know, and it enters our consciousness that this is a red flag sign.
Yeah. I wanted to ask you both about your experiences of getting news and NEWS2 adopted in the NHS, because when we were writing and talking about the development of NEWS2, when you look back at news, only 70% of places have actually adopted news themselves. So are you worried that there will be variation in the uptake of NEWS2, given still maybe just under a third of places haven't actually adopted news, which, given its evidence base and its benefits, it's slightly concerning that that's the case, isn't it?
So I'm a half full kind of person, and one could argue that 70% coverage of England has been achieved without any push at all, just the evidence, and now with a bit of push, and there has essentially been an effective mandate for the implementation of NEWS2, with the patient safety alert that's been released recently, with the sepsis sequin rewording that clearly states that if you're not achieving 90% of your patients screened for sepsis using NEWS2, you will not get remunerated. For the first time in my living memory, we have clear mandate that we should all be speaking the same language. And what's really interesting is when you talk to patients and you say, we're finally going to be using the same tools of communication from one environment to another environment, and everyone's going to be on the same page. They look at you and think, why weren't you doing this 20 years ago? Why is it only now that it's happening? And it's really interesting when you have these events, and this is what's so great about involving patients, because they see the wood from the trees. They don't see the silos. They see a pathway that should work. And it's the most powerful, persuasive thing one could imagine.
But why do you think it is that there are places that still haven't adopted news of any kind?
It's not out of a desire to be difficult. We have evolved in silos of care, I think, across healthcare. We're all busy, we've all got our heads down, we have our system for doing things. And you can see it on departmental levels, even within individual firms of groups of healthcare professionals. And, you know, they are experts in their area, there's no denying it. But it's, if you just dip your head above the parapet and actually see the impact of that silo mentality and a single way of doing things versus the multiplicity of incredible, dizzying arrays of early warning scores that were in existence, you can see potentially the benefits of that common language across the entire care pathway. It's the realization that patients don't just become sick in your little area, they become sick at home. They become sick down the shops or in the emergency department. And they are passed through multiple care providers' hands, multiple teams' hands. And if one thing means something completely different in one area compared to another, how does that advance our care for the patient?
It's perhaps also worth saying that this is a change in practice, and all changes in practice come with some difficulty, or often come with difficulty. Remember again that back 10 years ago there were 60 or 70 or 80 published early warning systems in the UK, and a whole lot more that were unpublished, and each of those had been developed with a lot of dedication and hard work and time, trouble and some money by given individuals. So up to a point you can, and maybe they got it to work pretty well in their particular hospital. So you could see after all that time, trouble and money, passion, investment, why they might not necessarily want to transfer to something that was just set out as a national standard from the beginning. But in the space of 5 years to get to 70%, actually I think is a massive change. And I can't think of many other changes in the health system that have occurred at that scale quite so quickly with relatively little push.
Do you, presumably then, you think the new sequin and the wording of the sepsis sequin to sort of effectively mandate NEWS2, that is a good move by the system, by the national leaders?
I think on balance it is. I mean, I think some people have a little bit of an inbuilt resistance to these sorts of national mandates, and sometimes being told to do stuff maybe discourages people, but I think on balance it will be a force for good, and I think we'll see that. And you know, I just go back, as Matt has emphasised several times, the issue is about having a common language. There may be one or two very slightly better early warning systems out there, especially the ones that take into account many more parameters than are available in NEWS. But the whole point of NEWS is that it can be recorded on any patient in pretty well any setting, from home to hospital. You don't need any background information, you don't need to put any tubes in the patient, and you can have a pretty good understanding of the patient's physiology in about 2 minutes. And the same score means the same thing across the board. That's a good thing.
And you obviously welcome the sequin as well, Matt. Is that the way to do it, do you think?
Well, no one likes a mandate, but at the end of the day, if we just, I think, carry on our own way, we're not going to really get to the root of solving or trying to solve deterioration, and I think sepsis. You know, because we need the data sets to tell us what we should be doing and where the evidence lies in terms of improving the way we respond to deteriorating patients, the way we respond to sepsis. And what I suppose everyone being on the same page and using the same physiological parameters allows us to do is potentially create some very large databases, particularly from those already electronic, to actually answer that million-dollar question: what is sepsis? What is deterioration? Where should our parameters really be? And opens the door for collaboration across acute providers, across the community, across ambulance, to actually get to the root of the almost too difficult pile, the how to improve deterioration. So it's a step beyond anything that has happened before in the NHS.
You've both just mentioned different settings, different healthcare settings, and actually that's perfect, because one of the questions we had from our registered audience was around the use of NEWS2 in settings that are not the traditional hospital ward. So particularly the question mentioned primary care, and obviously other community settings. This can be used easily in all those settings without any kind of particular modification or any change like that.
I think from an evidence perspective, at the moment, it hasn't been validated in primary care. What it strikes me as being is common sense, because people get sick everywhere, and if we envisage a needle in a haystack, the size of the needle and the size of the haystack varies based on the environment. So in primary care, the haystack's big and the needle is small in terms of picking up someone who's really unwell. In a hospital, the haystack is smaller, the needle is bigger. But it still happens, people still get sick, and the same for an ambulance service is picking up a patient in their environment. I suppose what we have to ask ourselves is whether we believe in physiology as being a predictor for death or whether we don't. And I'm firmly in the camp of having been a practitioner for many years now. People that die have physiology that gets worse and worse and worse before they die. The large-scale evidence proves this time and time again. So I don't think one environment is dramatically different from another when you're seeing someone who's unwell. Now, then the question is, because there's no current evidence for national learning scores, but although that is changing as we speak, and I note that a couple of Health Service Journal award entrants have focused on the use of NEWS and are collecting evidence to prove its worth in primary care settings. The question is, if we entail a communication system that is based around a physiological score that goes across the whole healthcare system, we will drop the ball less, because we'll at least be alerted to a sick potential patient in the community setting. We have stacks in various elements of healthcare. The ambulance stack, because there's only 30 to 35 ambulances in each region that are on the road at any one time. Multiple of those ambulances are queuing outside EDs up and down the country, meaning that you have a limited number to actually pick up the patients that are sick. You have ambulance controllers who are not always clued in as to how urgent that particular call for an ambulance is. And if we've got healthcare providers that have seen a patient, that have assessed physiology and applied their clinical judgment, because that's the key combination, they can give a score that might enable that decision to be made more safely than it currently is. Rather than, he's sick. It's he's sick, his NEWS is 7, and I think he may have an infection and be septic. How much of a difference is that extra piece of information when you've got, the ambulance program was on last night and recorded 2,000 calls in 12 hours. So you can imagine the volume of calls these guys have to put up with, and actually to differentiate who should be seen first. An average medical take in my place on a Monday might see about 20 or 25 medical GP referrals waiting to come in. If I don't have the physiology and the risk communicated to me in a way that I can determine who I should see first, how do I decide who to prioritise and place? Should I put a patient with someone who might be sick but I'm not sure in my waiting room, waiting for their deterioration and to end up requiring ventilation in an ambulatory care setting? Or should I instead place that patient in a resus department because I'm aware of the physiology and the risks? So the communication is a key element. NEWS will only ever be an adjunct, a decision-making assistant. Judgment is key to all of this, and no one's taking that away from anyone. But what it does is, and where it really shines, is getting people on a scoring system that works everywhere else in healthcare, across ambulances, across the whole of the hospital system. That means we can actually identify those most at risk at the earliest possible stage. Our care home staff and our nursing home staff are very keen on implementing across the whole of their services. So we have the potential for a really joined up system of detection, recognition, escalation, review and intervention.
And it's perhaps worth highlighting that in some parts of England, west of England for example, or indeed across Wales, across the whole country, this is already in place. So in Wales they are using it in all acute hospitals. There's only one ambulance service, but in the ambulance service in Wales, and in an increasing number of community hospitals and care homes and GPs and what have you. So if you want to learn how to get it across an entire system, Wales or perhaps the west of England is the place to go, and the rest of us are following on behind.
I mean, I think it's a really interesting point, and I interviewed Professor Brian Williams when NEWS2 came out early this year, and he sort of made a similar point around it will create a language which allows almost within seconds for clinicians in different settings to communicate the level of seriousness that this patient is experiencing, and you can make that judgment within those few seconds to prioritise your patients. But how much of we've talked about adopting this in acute hospitals and across trusts, etc. We're talking now in different settings. How much of a challenge would it be to get this adopted out in the community, do you think, John?
Well, as I say, in some places it's already happened. They've done it in Wales. They've pretty well done it in the west of England. And so we can all look to them to how it's done. What I think needs to happen, and I found this even in my own hospital, so I work in a trust which has got 3 hospitals in it, and a couple of those hospitals have very specialist services, and people in those hospitals were a little sceptical about using NEWS. And what you need to do is physically to visit the site and walk around and look at the patients and check their vital signs and see how they fit into the NEWS schema as opposed to whatever schema is already being used, if any is already being used, what it would mean in terms of alerts and possible treatments. And my own experience is by taking that sort of hands-on approach and looking at real-life patients with the people that are looking after them, that very quickly you can help people sort of come to understand that this common language will be helpful for all. And there's no doubt, I think, that having some resources that you can give to people is helpful, and they did a lot of that in the west of England, so they created resources. And the College of Physicians have created a very nice free online training program that anybody can access that walks you through the steps of NEWS and where it might be applicable and where it might not be. And for any skeptics, I would just encourage them to look at their own patients wherever they may be and see what a NEWS score would say about the patients that are in front of them. It doesn't have to be used for everybody, and if you're a GP, most of the time you will not be recording a NEWS. Yeah. But if you're on any doubt, if you're thinking I might need to refer this patient to the hospital, I might not to, the decision making around that will be aided by taking some vital signs and adding up the NEWS score. And a high NEWS score is important, and indeed a low NEWS score is a pretty good discriminator that the patient isn't going to get really sick anytime soon. Let's remember, of course, that NEWS scores also need to be taken serially, when we're genuinely potentially concerned about a patient. And other factors come into play. It's not the only thing. At the end of the day, we're measuring a number of important vital signs, but there are many more things that we can look at. And someone like Matt can make a judgment about other aspects of the patient, but what the NEWS helps us do is also people who are not as well trained as Matt, haven't spent all those years in medical school, to do some vital signs and say, yeah, this patient's sick, and to make a call and have an authority because they say the score is high and it means something, and we have data to say it means something.
Another question that came in from our audience was around some of the challenges that might come around adopting NEWS and getting it used by staff, and one person particularly cited the issue of the workforce pressures, and because clearly you have to be doing this on a regular amount of time, etc., observations that can be sometimes missed because the staff are under pressure. They can't do all of the things that they need to do within a given time. How big a challenge is that? I mean, I know we're broadening this out now to sort of effectively challenges on the NHS, but that is an Achilles heel of NEWS, isn't it? If the observations aren't done consistently for whatever reason, it kind of weakens the assessment, doesn't it?
I think there's an acceptable standard of training that we have to achieve and competency at doing a set of observations by any healthcare professional, be it from the most eminent doctor to the perhaps people lower down. Regardless of who you are and what you think your qualifications are, there is a degree of competency that has to be achieved. We're going from a situation where you can buy an oxygen probe on Amazon for less than £15 and a blood pressure cuff for less than 20. So our patients are doing this. And I suppose my question back to you is, do you think it's really right that we should be in a situation where our healthcare professionals are not doing what their patients can do for themselves? And you know, it's not a difficult thing to do. It does take a bit of time, but we know time and time again from critical incidents that have occurred across healthcare that having a full set of physiological observations is a really important thing to do when you're assessing a patient. And we've had plenty of examples when that hasn't been done in various healthcare settings, and patients have ended up in significant harm because that risk has not been recognised early enough. So if we're basing our logic that patients who are deteriorating require a full set of observations, the next question should be, how do we prompt to improve reliability of taking a full set of observations? And this is another area where NEWS really shines, because it makes you do what you should be doing anyway. As NCPOD showed in its analysis of community settings, full physiological observations recordings in patients with confirmed sepsis who had very bad outcomes, we know that in community settings there was roughly a 25 to 30% reliability rate of doing observations in this very sick category of patients. Within the same report, we know that paramedics were achieving 95 to 99% reliability of observations. So it's about, as John says, picking the right patient. Are you worried about the patient? You know, is there concern that this patient might be, you know, quite physiologically unwell? And also a certain amount of situational awareness of your own situation. Like, this is the 15th patient I'm seeing in an afternoon busy clinic, and my decision making is a bit shot because I've been really busy and I'm a bit tired. And this is where it helps, that decision support of, I'm not quite sure, but I'm just going to check the physiology and see if that can assist my decision making, and either reassure me that actually this patient has normal physiology and I shouldn't worry too much, or that news of 7 is a bit of a scare and slightly left field. And there are so many stories about this, both from the personal experience of GPs who've taken this on or in community settings, and videos. There's great films out there that really describe and outline the experience. But what we want to be in a position to encourage is that people in community settings don't need to have a disaster to change their practice. They can learn from others' disasters. They can prevent it, you know, and stop the risk of this happening to them themselves. Because what you don't want is to have a face-to-face with a coroner and saying, actually, I didn't do all the physiology here. I didn't think the patient was that sick. You know, there's a step before that, which we need to get to.
Yeah. I think it's also worth thinking about how important organisations make this thing. Is it part of their culture that vital signs, measuring physiology, understanding physiology is actually important? And I do suspect that a few years back we did fall into the trap, in the hospital anyway, of relegating the collection of vital signs to the lowest paid and the least trained members of the team, and implicitly that maybe says something about how important we thought that was.
I mean, I'm aware of some acute hospitals who have actually changed the staff they use. So I think Coventry and Warwickshire have actually said their healthcare assistants are no longer doing observations. It's registered nurses, because of some research they did which showed the outcomes for the patients were markedly better if a registered nurse was doing the observation, spotting the deterioration effectively. So it's a good point that people need to consider, isn't it? The education of the staff doing the work.
It is. I mean, I think it's perfectly fine for healthcare assistants to take the vital signs, but they need to be properly trained. Exactly. And they need to be working in a system that helps anybody who's taking the observations be clear about what's okay and what's not okay, what the standard is, and the early warning score, the national early warning score, is only the beginning of the process. If things are abnormal, what's the mechanism by which help can be obtained, and is that made easy?
One last question, another one that came in from the audience which I quickly wanted to touch on, was around setting the thresholds for escalation of NEWS2, and some people have said that some places will set their own thresholds that will vary, and there's a risk there that people set a threshold either too high or too low. And is that a risk with NEWS, and how do we overcome that potential problem?
But I can only really speak of the document itself. So the RCP NEWS2 document is really clear about where the escalation line in the sand should be in terms of both the frequency of observations, who you need to escalate to, the competency of your core team, and at what level of urgency and what time frame. So I think it's a bit imaginative and very off-piste for providers and organisations to think they know better than that. And if they do think they know better, then measure it and prove it. Would be the call back. But until you get to that point, why don't you just do what everyone else is doing? So, I respect individualism and autonomy, but at the end of the day, you have to have a degree of standardisation to enable it, and you have to prove your individuality when compared to the best of the rest.
So, I would follow on from that. If people choose to deviate, and I think some people will, they must only do it if they are absolutely measuring what impact that has, and if they find that they have a better system, then they can tell the rest of us about it. But it's also worth remembering what a sort of transient workforce we have. If you think about doctors in training that move from one hospital to one hospital to one hospital, and nurses that are doing agency shifts here and agency shifts there, and so on and so on, having a system that is very different in different locations is not a smart way to proceed, and you can't imagine that other industries would work in that way. So, unless there is a real body of evidence that very definitely different levels of escalation should be used, stick to the one that's been recommended.
Yeah. Sadly, we're nearly running out of time, but so I just wanted to ask both of you for a final thought, really, on NEWS2 and the benefits that it can bring. So, Matt, from your perspective, what's your sort of final message to the audience here? How significant is this? They should grasp it with both hands, presumably.
I think it's embracing the opportunity. It would be my message. We finally have a means of actually pulling together a single language of deterioration, of incorporating sepsis infection within that, and actually speaking to the truth, which is that when someone comes in and you don't know what's wrong with them, you have to have an aligned common pathway with the same language that goes across the whole of healthcare.
And I would just add to that two things. One is to reinforce that news can be easily recorded in pretty well any setting in about 2 minutes. The common language thing is really important, and now increasingly more and more of us do have electronic health records. Start thinking about collecting data that will help us with the next development. So NEWS2 is about as good as we've got at the moment, and maybe in 5 or 10 years we'll be able to develop it a little further when we have some information to back up the next change.
Excellent. Well, gentlemen, thank you very much for your contribution this afternoon, and I hope you guys at home have enjoyed today's session. I think it's given us a lot of food for thought about what could be a very powerful tool for the NHS and could save thousands of lives. We'll be talking about this at the Patient Safety Congress with Matt and John again, and we'll be there with the International Society for Rapid Response Systems in Manchester on the 9th and 10th of July. I look forward to seeing you there, and I hope you've gained some information from today. Thanks very much.